In working-aged adults, the primary driver of legal blindness is an inherited flaw in the genetic code, a silent mutation that triggers a sudden, life-altering collapse of the visual field. These inherited retinal diseases affect roughly 1 in 3,000 people. Pinning down a diagnosis is difficult because the condition can be driven by over 400 different known genetic mutations. The specific mutation determines how a patient's sight fades. In rod cone dystrophy, the photoreceptors responsible for low-light vision degrade first. Patients lose their ability to see at night, while a shrinking black border slowly claims their peripheral vision. Cone rod dystrophy produces the opposite effect. The cone cells break down first, creating a central blind spot that obscures faces and fine detail. Because only the rods remain, the eye becomes hypersensitive to light, turning everyday brightness into a blinding glare. In the early stages, these structural changes often manifest as sudden clumsiness, tripping over curbs or losing track of a ball during a game. These sharply contrasting symptoms demonstrate that IRDs are distinct conditions, each requiring a direct physical investigation of the eye's architecture to pinpoint the source of the failure. Traveling through the pupil to the back of the eye reveals a biological landscape undergoing localized structural collapse. This map classifies retinal failure based on the region affected first: the central macula, the pericentral ring, the midperiphery, or specific concentric zones. The most common form ignores these boundaries. Panretinal pigmentary retinopathy sweeps across broad, irregular sections of the tissue all at once. We observe this destruction in rod cone dystrophy, a phenotype affecting approximately 1 in 4,000 people. Clinicians look for a diagnostic triad: the formation of dark, spiky bone spicules, surrounding blood vessels thinning out, and a pale, sickly white optic nerve. While the diagnostic triad confirms retinal death, it provides no information about the underlying cause. Solving the mystery requires an investigation of the patient's genetic code. Deep inside the nucleus of the photoreceptor cells, these complex diseases strictly follow the mathematical rules of Mendelian inheritance. In autosomal dominant inheritance, a single variant gene causes the disease, giving each child a 50% chance of inheriting it. In autosomal recessive conditions, 2 copies are needed. Healthy parents act as silent carriers, passing the trait down until it unexpectedly combines in a future generation. X-linked inheritance adds another layer of complexity. Because biological males have only 1 X chromosome, a single variant gene ensures severe symptoms. Biological females have 2 X chromosomes. To Down's gene dosage, each cell randomly shuts down either the maternal or paternal X chromosome during early development. This random shutdown can lead to genetic skewing. If 80 to 90% of cells express the mutated gene, the patient suffers severe vision loss. But if the split is an even 50-50, the healthy genes compensate, resulting in a milder, unpredictable phenotype. This genetic lottery creates a massive spectrum of symptoms and ages of onset, making patient management a significant clinical challenge. With over 400 different genes at play, identifying a specific condition requires moving past visible symptoms to perform precise genotyping on each patient. Cracking this code allows clinicians to match a patient's specific mutation with emerging custom-tailored treatments, turning a genetic map into a path toward a cure.